Real life, sir.
Okay, good evening, everyone, and welcome to this Embrace Meet. This Friday evening, it's a pleasure to host all of you here today. And there's some exciting topic that we are going to discuss, and we have a very esteemed panel here today with us. So, without further ado, I'll just take 2 seconds to just give a brief regarding our company. We are Genova, and basically we have made a difference in more than 10,000 lives till date. But we aspire to touch millions of those in the coming times, and we aspire that we'll become the top 10 technologically driven companies in the world. So, what are we? We are basically based in Pune. It's a biotech company in the business of transforming healthcare. Do we do? We basically manufacture biotherapeutics, and we innovate biomanufacturing technologies, and that's how we want to transform healthcare in the coming times. So this journey has been quite remarkable. We've started on 2nd Feb 2006, and we've launched Relaxim, Memgras, Wintor, and over the years launched a lot of other molecules, including vaccines and Hamsil for oncology, Tenectase, and so on and so forth. And last year, we also launched Hamilton Junior for pediatric cancers. So we are placed in multiple therapies, including cancer care management, stroke management, renal and transplant and cardiac care as well. And we are also working on a lot of mRNA vaccines and biotherapeutics in the coming times. With this brief, I won't take much of time. And of course, we have our program director, Dr. S.H. Advani. Sir is a medical oncologist at the Shrishut Hospital, Mumbai. Sir is definitely not needing any introduction from our end. I'm sure everybody is well aware about Sir. And Sir, it's a huge pleasure and it's an honor to have you here today for this Embrace Meet. With this, we also have our moderator, Dr. Akhil Kapoor, medical oncologist at MP, MMCC, and HBCC Varanasi, and our esteemed speaker, Dr. Advaita Gore. Sir is again from Sefi Hospital, Mumbai. We welcome you here, sir, today. We also have an esteemed panel here for an engaging discussion going ahead. So we have Dr. Abhishek Kakru from Ahmedabad, Dr. Amit Kumar from Patna, Dr. Anuradha Mehta from Mumbai, Dr. Deepak Upal from Patiala, Dr. Jaishankar P from Ernakulam, Dr. K. Lakshmi Priyadarshini from Vijayawada, Dr. Pallavi Redu from Noida, Dr. Ravi Jaiswal from Raipur, Dr. Sandeep Ganguly from Kolkata, and Dr. Trivikrama Rao from Hisar. So we welcome this esteemed panel here again today for this wonderful discussion on the role of eribulin, especially in the MBC setting, which is metastatic breast cancer. So with this, I would like to hand over the dais to Dr. Advaita Gore for his brief session on the role of eribulin in the treatment of MBC, followed by the panel discussion. Over to you, sir.
Thank you, Genoa, for having all of us here. You will be changing the slides from your end, or I would do that?
Yes, sir, I'll do the same. No problem. Sure. Just keep on giving me the cue.
Done. So we are here to discuss about what role does eribulin have in treatment in MBC, and we just heard from Genoa that eribulin or Embrema is one of their important molecules, and we all have been using this in clinical practice, especially in not just in TNBC but also in the HER2 positive situation when we are using it in combination with single agent anti-HER2 therapy. Next slide. Can we have the next slide, Donald? Yeah. So eribulin is a very different compound. It's very difficult to isolate and to make. And this essentially is a non-taxane. It's a microcyclic ketone analog of the natural product, which is halichondrin B, which was discovered in a marine sponge. Eribulin works by binding to the growing end of the microtubules. It blocks their extension and prevents them from capturing the chromosome, and this leads to halting of the cell division. Eribulin also works by another mechanism which reverses the EMT, the epithelial mesenchymal transition, making the cancer cells less invasive and more responsive to therapy. There is also another third mechanism of vascular remodeling which eribulin causes, and this eliminates the tissue hypoxia, thus improving oxygen and the drug delivery. overall, all of these leads to better tumor control and potential enhancement of the effect of subsequent treatments. Next slide. So in terms of metastatic breast cancer patients, eribulin, as we see here in this study, these were initially 66 consecutive patients with MBC who underwent eribulin monotherapy. And in terms of patients who are, the first one is all patients, treatment before eribulin and post eribulin. The second rectangle is the luminal subtype, and the third one is the triple negative. We see that the shrinkage is maximum in the TNBC, and it has a potential anti-tumor mechanism to prevent new metastasis. Next slide. So EMBRACE study has been the basis of approval for eribulin, and EMBRACE was a phase 3 open-label randomized study which was published in Lancet in 2011, and this was the first major single-agent study of a cytotoxic or a biological agent to show significantly increased survival in patients who have been heavily pre-treated for a metastatic breast cancer. All of these patients were allocated 2:1 to eribulin, which was given as an intravenous push over 2 to 5 minutes on day 1, day 8 of a 3-weekly cycle versus treatment of physician's choice. And most often the treatment of physician's choice was vinorelbine, gemcitabine or capecitabine. Next slide. What do we see in the study? That 16%. 123 of 762 patients had HER2 positive disease, and 19%, that means 144 patients, were triple negative. The median duration of eribulin treatment was about 4 months, and the median duration of treatment of physician's choice was only 2.1 months. For those patients who were receiving chemotherapy, almost 238 patients, and just 1 month for patients who were on hormone therapy. Next slide. In terms of safety and endpoints, serious adverse events occurred in about 25% in the eribulin arm and 26% in the physician's choice therapy arm. Adverse events leading to therapy discontinuation was seen in about 13% and 15% of the same arms respectively. The grade 3 or grade 4 adverse events that occurred more often with eribulin than the treatments of physician's choice were mainly the hematological toxicity and the peripheral neuropathy, like neutropenia, leukopenia. Next slide. So overall, 1062 patients received eribulin. Median overall survival was 15.2 months with eribulin and 12.8 months with physician's choice therapy. And when we look at the overall population, the HER2 negative and the triple negative population, these three seems to be faring eribulin much more. Next slide. So TETRIS study, this was a second-line eribulin in TNBC, which looked at early inclusion of eribulin in the sequence of therapy, whether it can increase the inherent clinical benefits. And this was a retrospective study, multi-centered, 44 metastatic TNBC patients treated from 2013 to 2019 with second-line eribulin. This was an Italian study across 14 Italian centers. And we see a PFS of about 17 months, overall survival at 1 year of 43%, 2 years of 13%. Next slide. So eribulin activity was unrelated to the number of previous lines and the type of metastatic involvement. This has been a retrospective study from India in previously treated MBC patients who had at least 2 prior lines of therapy. 78 patients, median number of previous chemotherapy lines was 5, and a median PFS of 3 months was noted. Median overall survival was 7 months. Next slide. So what are the latest advances in 2025? Next slide. I think we are back to the same one. Yeah. So these are the long-term outcomes of eribulin-based neoadjuvant chemo for TNBC. This was published in May 2025. This is the JBCRG 22 study. 99 patients were followed up for almost 5.5 years. In terms of PATCR, 95% patients were disease-free, 100% were alive after 5 years. Non-PATCR patients, 71.4% were disease-free, 80.2% survival rate. These patients were grouped on basis of HRD and the germline BRCA. Group A had patients who were HRD positive or BRCA mutation positive, and they compared combination of paclitaxel carboplatin followed by anthracycline in a sequential manner versus eribulin carboplatin followed by anthracycline. The group B, which were HRD negative or those who were more than 65 years of age, compared eribulin with cyclophosphamide versus eribulin capecitabine. If the first four cycles didn't work, then they were switched to the anthracycline. There were some data which suggests that high lymphocyte count patients did better, and patients with no neutrophil to lymphocyte ratio, NLR less than 3, had better outcomes. So the study showed that patients with HRD positive tumors had 90% survival after 5 years, and eribulin based therapy was effective, especially in those patients who achieved a PATH-CR. Next slide. In terms of a potent second line therapy for MBC, this was a median response duration of 25 weeks, which was seen after 6 infusions, a multi-center observational study, which was published in June this year. They were treated by eribulin in second, third, or fourth line between September 2011 and June 2018. 84 patients. Response was similar irrespective of the use, whether eribulin was used in second, third, or fourth line. Median overall survival was 24 months, and the main prognostic factors for survival were duration of response, which was statistically significant, and a progesterone receptor positiveness was also associated with progression-free survival. Next slide. This is another study which was as an abstract at ASCO, eribulin in HER2-negative breast cancer. This was the real-world data in the era of precision oncology. HER2-negative metastatic breast cancer patients treated with eribulin. This is a Spanish study between January 2016 and December 2022. 211 patients retrospectively evaluated and followed up till March 2024, median age of 62. 53% had a high Ki67 and 18% were metastatic disease at diagnosis. 6% patients received it as first line, 17 as second line, 27 as third line, and almost close to 50% as fourth line or later. And the PFS with eribulin was 4.676 months, and overall survival was about 10.75 months with a median follow-up of 12 months. Overall response rate was about 43%. Fatigue, asthenia, neutropenia, and nausea were the common toxicities, and the real-world data complemented the results of clinical trial by providing information on the efficacy and safety treatments as per the conditions of routine clinical practice. Next slide. So what do the guidelines suggest? Next, please. So in terms of stage 4 metastatic breast cancer, whenever that we are looking at systemic therapy, there are NCCN which mentioned preferred regimens, anthracyclines, taxanes, antimetabolites, or microtubule inhibitors. Eribulin is a part of the armamentarium when we look at second line therapy and beyond. Next slide. The ESMO guidelines 2025, TNBC second and further lines of therapy. After progression, all chemotherapy recommendations for HER2-negative disease apply for the TNBC such as eribulin, capecitabine, vinorelbine, or gemcitabine. Next slide. So I think with that I end and I hand it back to the team, and let's have an interesting panel discussion. Thank you, Ram.
Thank you so much, Dr. Gore. Now I invite Dr. Kapoor to please facilitate the panel discussion. Dr. Kapoor. Advani sir, if you suggest, we can begin the panel discussion and you can have the felicitation.
Ronak, just give me a minute. I'll check with Akhil sir.
Yeah. Dr. Kapoor is facing some technical challenges. Apologies, everyone.
Sir, Akhil Kapoor's uh,
Dr. Kapoor, Pooja sir has joined. I can't see him.
Ronak, actually, sir is facing some technical issue.
I think we can begin the panel discussion then until sir joins back.
Sure.
Yeah. Advani sir. Okay, we'll start with the first question. What percentage of your metastatic breast cancer patients are pre-treated in anthracycline and taxane in neoadjuvant or adjuvant settings? Dr. Jaishankar, would you like to take this up?
Yeah. We have usually two kinds of patients, like patients who are de novo metastatic and naturally patients who have been treated with a curative intent previously. So, patients who have been treated with curative intent previously, almost everyone has had anthracycline and taxane exposure. And for patients with de novo metastatic, again, subdivisions like luminal ERPR positive, HER2 negative disease. Actually, this cannot be like answered in a single um, uh, number because we have so many types of breast cancer that we get. And overall, most of our patients, before we think about eribulin, most of them would have definitely had taxanes and anthracyclines. Definitely taxanes, anthracyclines still less.
Thank you so much. Dr. Kapoor, please take it over from here.
Yeah, thank you. Had some technical glitch and that is sorted. Thank you. So we had a very important discussions regarding the utilization of eribulin, and it's very important to understand these points when we're deciding, and especially when we are deciding the sequence of treatment. So that is the most important point. We have our own data published as well for eribulin in metastatic breast cancer, 100 plus patients data. And I think that has helped us to understand how we sequence the treatment is really, really important. So I will also try to understand some of the important points relating at which line of treatment our colleagues do utilize this treatment in the routine practice, be it in triple negative, be it in hormone receptor positive. So I would like to take a comment from each one of the panelists first. So, yes, Dr. Abhishek, you can start. Yes.
So I think as Dr. Jaishankar already was discussing, so first line HER2 negative, HER2 positive, HER2 negative, obviously AC taxane is already gone. And once the patient is metastatic, then the question is you are looking at closely at the BRCA mutation. And so that will basically decide whether you're using eribulin or you go towards BRCA more. So eribulin will go in the later line. And in HER2 positive, it's a different ball game altogether. I don't think we can discuss that here because that is another
Complete,
algorithm
yeah,
altogether.
yeah,
So
correct.
this possibly relates to HER2 positive MBC. And so you're looking at patients, as he already alluded, primary metastatic, do you know what they have received? Whether they are still the disease burden is low, you want to give them hormones only, you want to give them chemotherapy, what is the BRCA status. So that might derive first set. So second line and beyond, as I can tell you, it is one of the options as the guidelines suggest, depending on what other options the patient has.
Yeah. So it's a bit complicated. It's not so simple like being married or unmarried. It's actually complicated. So it's not a simple answer. So completely agree with you, Dr. Abhishek. So this is an area which doesn't have any single answer, and in every situation, prior treatments, patient's fitness, and patient's biomarker status help us to decide the therapy. There's no exact sequencing which can be commented upon for individual patients. Dr. Amit, if you are available for comment, do you consider utilizing the Japanese data which is available, randomized trial, HER2 positive patients, combining eribulin plus trastuzumab plus pertu in the first line in some selected patients?
Till now, not, I will say, but definitely it's the data is it suggests that we can use now eribulin even in the neoadjuvant setting and this. But still, apart from, we need, I'll say, more data regarding this to use it in the clinical practice right now.
Okay. So, as per the randomized phase 3 data, at least we have that it is at least, though not superior, but at least not inferior also, it seems. But I agree with Dr. Amit. We might, because both drugs, if it had been without neuropathy, would have been more confident utilizing it, because the main concern with docetaxel or taxane is neuropathy, and eribulin also has some significant neuropathy in the long term. So that limits utilization in the first line in HER2 positive group. But yes, there is now data to suggest that can be considered, especially one part is that the somewhat low alopecia rate with eribulin as compared to taxane, which is also somewhat helpful, because sometimes we get patients who are young and they reject taking any treatment because of fear of alopecia. Despite utilizing scalp pooling or any device, I think taxane-induced alopecia is not very well taken care of. And in some patients, that is why we take help of this eribulin, where we want less alopecia. It has also alopecia, but some much less than taxane in our practice. Any comment on that perspective, Amit? Dr.
Yeah,
Amit?
most important thing. So alopecia is really challenging, and now we are getting younger patients of breast cancer practice. So we have to definitely think about that. Eribulin, I'll say, is a much more easily tolerable drug. So the side effect profiles are much easy to manage with. Apart from neuropathy, patients definitely have, but many patients even goes very smooth on eribulin without this neuropathy complication in our setting. So as a population, I think so it's a easily tolerable drug.
So this has been an advantage, and we might select some of the patients based on this features in the routine practice in the first line setting also with HER2 positive settings. Moving further ahead, we shift to the next slide. Moving further ahead, I will request Dr. Deepak to give his comment. When you are selecting a treatment for triple negative breast cancer, and the patient has progressed on taxanes and anthracyclines, how do you sequence apart from seeing the BRCA status? Dr. Deepak, some important pointers?
See, apart from the BRCA status and the PD-L1 status, regarding the systemic chemotherapy, cytotoxic chemotherapy, right now the eribulin is placed in the third line setting mostly after gem-carbo in the routine clinical practice. But the data is coming and promising to shift the eribulin in the second line setting also before the gem and carboplatin.
Actually, in our experience also, if you are able to utilize the drug in earlier lines,
Earlier settings.
very important, you will get much better PFS. So
plus the tumor is left less resistant if we use in the earlier lines.
Correct. So this is like that. If you are sending Sachin Tendulkar to bat at 9 down, then how we expect him to score runs? So something like that. Advani sir, any comment on this? If you are available for comment, sending the good batsman at 9 down, though he can score there as well, but whether is it feasible to get a good score? I think sir is not able to give comment presently, but yes, this is an important point which I have found in the routine practice. And whenever you utilize it at somewhat earlier line, it works somewhat better. Dr. Jaishankar, I see you eager to give some answer and contribute to the discussion.
Yeah, I think sir, in triple negative setting, like I would place carboplatin ahead of eribulin. There is actually the one is the response rate. Eribulin, whatever said, I see the response rate to be modest, and I find carboplatin to be more practical and more having a more response in TNBC types. And also, if you look at the cost benefit ratio, so I'm just speaking my heart out from what I do in my practice. And if you look at the cost benefit ratio also, I find like carboplatin to be more practical, usable, and more efficient than eribulin.
Okay, okay. So your point is valid on definitely. I would request Advani sir's comment, sir.
Yeah.
Sir.
Yeah, first of all, I'm so happy to meet each one of you, giving such a nice, insight into the eribulin. I must say that I like the eribulin. And after the first doses with paclitaxel and all, we are the second line. And before eribulin came in, our second line was gemcitabine and cisplatin. That was a normal routine. But I think nowadays, because 11 and the eribulin is such a drug that side effects are very less, very easily tolerable, and I think also more effective. So I think normally I use as a second line after the failure, the relapse. So it's quite my favorite sort of a thing. Use the eribulin.
Sir, is there any limitation of number of cycles of eribulin, or have you used up to what is the maximum number of cycles a patient can tolerate with eribulin?
I think we have given 6 doses. Personally, I feel that any drug which does not work for 6 doses, giving it 9 doses will not help. So 6 doses is a solid tumors. 6 doses is more than enough.
The patient is responding. Can we continue more than 6 doses, or you have to stop at 6 without if there's no toxicity even there?
If it shows continuous response, you may continue.
Thank
Yes. So a very important comment by Advani sir that eribulin is an important drug that needs to position at a correct point. And as I try to get a comment from sir on the point that if you send Sachin Tendulkar to bat at number 9, so we might expect scores of hundreds from him, and he is still the highest test century scorer, despite we expected Kohli and others to go past him, but that has not happened. So something like that remains the key, sending the batsman at the correct place to get the maximum benefit from the treatment. Yes, sir. I think, do you agree, sir? Advani, sir? I think sir was unable to mute. It's okay. It's okay. We have already got comments from sir. So Dr. Lakshmi, now moving further in the discussion, when we are looking at a hormone positive breast cancer, does eribulin is there in any part of your treatment armamentarium in your selection group? Dr. Lakshmi, if you're there. Yes.
No, I haven't used eribulin in hormone positive cancers because maybe in future I will try after all the lines exhausted like CDK4 inhibitors, exemestane, letrozole, followed by conventional chemo. I haven't got a chance to give eribulin in hormone positive till now, because many of the patients are have prolonged life for initial CDK4 inhibitors and letrozole, and after that next line hormone therapy, after that another line hormone therapy, after that conventional taxanes. So that's my practice. I haven't used eribulin in hormone positive breast cancer till now. I have used it when I was in postgraduate institute, but as a consultant till now I haven't used.
Okay, I agree that in hormone positive we are having so much improvements in hormonal therapies that we are trying to get much better outcomes with augmenting the hormonal therapy, CDK4/6 inhibitors, and nowadays we have imported capivasertib commercially. We have trials of capivasertib. We have now drugs like SERDs coming in, elacestrant coming in, being utilized. I think our main focus is towards those. But if I would request the MCure team to forward our published literature of 100 plus patients. In hormone positive patients also, the PFS was actually somewhat better than TNBC because of the definitely better biology of the disease. And it is not that eribulin doesn't work in hormone positive. This is an important point which I wanted to highlight here. But yes, I completely agree. In hormone positive patients, we have so many drugs to select. But when you come to that post-hormonal therapy, when you have started chemotherapy, I think eribulin can be considered there, and at the correct time. You don't need to keep it for the last line. I agree with Dr. Lakshmi. In hormone therapy,
Yes.
it's not a very common practice to utilize, but it can be considered. Dr. Deepak, you wanted to say something?
Plus, in later lines in hormone receptive patient, it may help us overcome some of the hormonal resistance also and re-challenge some of the hormonal therapies as a desperate attempt, maybe as of now. But if the future literature improves, this role can be explored also in overcoming the hormonal resistance.
Completely agree. So again, I would request the MCure team to forward the literature which we have published that included a lot of patients with hormone positive patients as well. And that has completely shown a significant improvement PFS with eribulin and hormone positive as well. So don't reserve it only for triple negative. Hormone positive patients also tend to respond well, and in fact somewhat better because of the better biology of the disease per se directly. Let's come to Dr. Pallavi. And again, I would request to comment on other subgroups. That means patients with brain metastasis where the patient received radiation, patient has been treated with platinum. So how to select the further treatment options? A patient has not been challenged with immunotherapy in initial first 2 to 3 lines. Would you consider immunotherapy down the line?
So recently I have actually placed one patient with eribulin with pembrolizumab in triple negative. That is in the second line. And so far I have given 4 cycles, and the patient after 3 cycles, the response was good. Partial response was actually more than 30%. So this is the only one recently I have introduced. Otherwise, I used to use only eribulin as a second line. Now only started in practice. Before that, third line I was using in triple negative breast cancer.
It's a very important comment from Dr. Pallavi. In a tumor where you have an option to combine with a drug which doesn't have overlapping toxicity, is good to combine. And immunotherapy definitely can be combined with taxanes. Immunotherapy definitely can be combined with eribulin. And eribulin plus pembrolizumab is one of my preferred treatment options in triple negative breast cancer, specifically where the PD-L1 is high. So we know immunotherapy alone would not work. We know eribulin will give PFS of short duration. So let's combine them. They don't have overlapping toxicities, and there it will work very well. And as Dr. Pallavi is trying to highlight, so this is a very good combination, and we try to combine immunotherapy with eribulin when feasible. So this is a very important approach that should be kept in mind while deciding treatment options. And it's good to know that some have utilized this combination, and I'm happy to see that. And we will be trying to collaborate the data of eribulin plus pembro also, so that we have at least data of 20-25 patients. Then we will be able to publish that data. We have data of around close to 12 patients already, and we'll try to collaborate the data as well.
How was your response?
Yeah. Median PFS is close to 7 to 8 months at least, and in third line setting in triple negative breast cancer, that is considered very good actually. So I'm happy with the responses. So anybody would like to comment on this point? Combination of immunotherapy with eribulin? Anybody?
Dr. Anuradha?
Yes, good evening, sir. So
ahead.
we've had two patients, sir, whom we've given a combo of eribulin with pembrolizumab. So far, the responses have been good, but the only problem has been myelosuppression. And as far as in TNBC, my practice, the maximum use has been in TNBC setting only as a single agent in third line and beyond. But with Pembro also, I have given two of our patients with a good PDL1 score.
Yeah, so actually, I completely agree. Myelosuppression with eribulin, though it is not so profound directly, but most of the time, as oncologist, we have preference of utilizing platinum early. So post carboplatinum, that is gem carbo, both are a very myelosuppressive drug. When you utilize eribulin, that is another very common problem. You are able to give the patient develop a lot of myelosuppression, and it becomes difficult to utilize adequate doses. So I completely agree
Yes.
with Dr. Anuradha that post gem carbo based treatments, though we try to utilize eribulin, but there it works less. So that is why my practice is to tend towards utilizing it earlier. If you are utilizing eribulin earlier line, immunotherapy will also work better because immunotherapy works much better in earlier lines. If down the line immunotherapy also doesn't work well, and try to combine it with the eribulin with pembro, there the data is much stronger, benefit is much. So you can utilize always gem carbo later, and but eribulin down the line with pembro, I think it will have toxicity. So completely agree with you, Dr. Anuradha. So it's another reason to utilize eribulin in somewhat earlier lines. So it's important.
So, but what about in de novo metastatic TNB patients in the first line with PDL1 positivity? Can we
So
replace
there I
with the
would stick to the guidelines because we don't have data in the first line directly. So I tend to utilize it in the second line and beyond. But de novo metastatic, I'm more confident about the other treatment options. But
taxane?
yeah. So in the first line, I cannot be over enthusiastic. We have to stick to the guidelines as well. So I completely agree. So there, de novo metastatic, more chances of utilizing other treatment options. But there is in the first line treatment option also there's an option to utilize both platinum with taxane or taxane alone with pembrolizumab. There, what is our practice is to utilize taxane plus pembro and keep carboplatin for the later lines unless the patient is in visceral crisis. So we keep one drug reserve for the later line as well, and also less toxicity in the first line. So that has been our practice presently. So utilize nab-paclitaxel with pembrolizumab in the first line. And the second line onwards, you can utilize eribulin, anthracyclines, or other treatment options as per the suitability and fitness. And also regarding the capecitabine also a good drug. The good part is that we have developed capecitabine in combination with cyclophosphamide, and that is called that is another drug which is a good action. But we try to utilize it again somewhat down the line because it is better tolerated even down the line. So it can be kept for down the line option when the patient is not very willing to come to the hospital repeatedly after so many treatments. Then the oral treatment options gets picked up easier. So Dr. Ravi, now we have those so many situations where we are trying to find the best pathway to utilize eribulin. Any importance do you think of eribulin having action on the immune inflammatory cells, immune regulatory cells? How do you see that picture in the routine practice? Do you think it is important that eribulin has other mechanisms also apart from just cytotoxic action of the routine chemotherapy, Dr. Ravi? Yes.
Thank you for the question. And I think eribulin by design itself is a different drug. And that's why they say that it's so difficult to actually make eribulin. And the Halaven guys actually, they say that, no one can replace like the original eribulin. So I don't know how these guys are able to get the drug equally at par with Halaven. So yes, it has got effect on the immunomodulatory cells. It has effect on Tregs as well. So, but then theoretically, whether adding to pembrolizumab, it is going to increase the immune response? I don't think we have answer for that question. But one interesting thing, Dr. Akhil, is I don't know whether eribulin works in the brain or not. Recently, we had a patient. So this was triple negative, first line nab-paclitaxel pembrolizumab, and second line capecitabine, and progressed with brain metastasis. And we radiated the brain. There were multiple meds, and then we started this patient on eribulin. I'm surprised that it's been 6 months and the patient continues to show response. So I'm actually not aware whether eribulin actually works in the brain or not. But for this patient, I think maybe I was lucky to that the drug worked.
So yes, it is always thought that this drug doesn't have so much of cranial penetration, but yes, the good point is that if the drug is able to act systemically, this patient you told had got cranial radiation as well, so that made the penetration better into the brain. That might be one of the very important reason. So drug penetration got improved and the patient had good action. So yes, we need to understand the various fine nuances, and as Dr. Ravi tried to highlight, there are so many things for which we don't have any answer actually. So we try to extrapolate it, but yes, it seems that there are so many points which are important to understand when deciding the treatment based on at least phase 2 data or the mouse model data sets, which we try to sometimes utilize. So completely agree with you. And that was a very beautiful point, Dr. V, which you highlighted about the brain effect. So the drug is actually effective. So after addition, it was able to have good cranial penetration, good giving good PFS of more than 6 months, and patient is still responding. Heartening to know that. Thank you, Dr. Ravi, for that comment. So let's move ahead, and let's come to a situation where the patient has received taxane and anthracyclines, and now the patient has become metastatic, and the patient is a case of again hormone positive patients, and patient has received hormonal therapy with the CDK4/6, fulvestrant, AIs, everything. So again, this is a very important area, which is my focus of publication as well. There we have found a very good responses, and I'll request Dr. Sandeep Ganguly, if is available for comment, that how do we see the projection of this drug in hormone receptor positive patients, and how should we teach our students and colleagues about the same?
The role of eribulin in the metastatic ER-positive breast cancer, I think in the present era is quite down, because as the previous doctors were saying, we have many options of the hormonal therapy. And now with the Destiny trial also, now with the TDXD data, so we really don't know where the eribulin will be placed. Because in that trial also the treatment physician's standard of choice was paclitaxel capecitabine. So I think for the hormone positive breast cancer, eribulin has a role in a much later line.
Okay. So I completely agree. So that important point of TDX, where it is either HER2 low positive, HER2 1+ or 2+ with FISH non-amplified. So that is also very important point to select the treatment. So very important point made by Dr. Sandeep, and we need to make sure we are utilizing the best possible treatment. But as I previously highlighted, when the patient is unable to take TDX, and we have utilized eribulin in hormone positive patients, and we have got decent responses, and our data is published also. And I will request again to the team to share this data set as a mail to all the colleagues who are attending this meeting. So again, one more point, selecting between treatment options, sequencing always remains a common problem. But again, if the patient is of triple negative breast cancer, patient has been treated with drug like olaparib, patient is BRCA1 mutant. Again, now a patient has progressed. Yes, I think when we are selecting between PARP inhibitor versus eribulin, the preference would be given to PARP inhibitor. That I think all will agree for that. Yes. So Dr. Rao is available for comment.
Yes, sir. Yes.
Yes, Dr. Vikram, yes. So if the patient has progressed on PARP inhibitor, I think you'll agree that between PARP and eribulin in triple negative breast cancer with BRCA, we'll go towards PARP inhibitor first, correct?
Yes,
Yes.
definitely.
So after PARP inhibitor progression, there is again a very common problem. If we give gem carbo based treatment, the patient will have a lot more myelosuppression post PARP inhibitor. That has been our experience in any cancer, in be it breast, be it ovarian cancer. Post PARP inhibitor, platinum has very poor tolerance, so we need to give a significant gap. So I think this is another area where we should combine it better with eribulin. And what do you think, Dr. Trivikram, sequencing in post PARP inhibitor?
Yes, sequencing is always a big problem while treating metastatic patients. So, but as discussed earlier, like eribulin used to be the second line or third line agent earlier. Now, with the advent of all these immuno drugs and the PARP inhibitors, so eribulin is being pushed into later lines more and more. So, yes, I agree. Myelosuppression will be easier or difficult with the gem carbo. So definitely post PARP inhibitors, eribulin might be a better option to use.
Yeah. So this is an important point, which I also learned that most of the time gem carbo was a usual default after progression of PARP, and most of the patient had significant myelosuppression, and we had to stop platinum. So now we have the policy of utilizing eribulin post progression on PARP inhibitors in triple negative settings, patients who are PARP as BRCA positive. So I think we tried to cover all the relevant points in terms of utilization of eribulin in various types of breast cancers. Yes, it has definite role in sarcomas as well, L sarcomas where it responds well. I think we did not test that, but yes, I completely agree. The role is much better defined and easier to select the treatment option. In breast, it is more complex. And yes, we need to keep remembering that, yes, in L sarcomas, eribulin works good, and we need to keep that also in picture. Thank you to all the panelists and the colleagues for active participation. And it was very heartening to see the responses. We had some learning exchanges. Thank you, everyone. Back to the organizing team.
Thank you so much, Dr. Kapoor, for this wonderful delegation. I'll just request Dr. Advani, sir, if there are any final comments from your end before we close for today. Sir, you're on mute at the moment. Irfan, can you please help?
Yeah, there was a lot to learn from the 1 hour of discussion, and I think many things became clear. But I think one thing is very clear, that in the metastatic setup, eribulin will be used at some stage, whether it's the second line or third line of metastatic setup, eribulin will be used. The sequence can be different, and the sequence is decided more by the side effects. So if any drug which has a less side effects will be used first, and if it is equally effective. So I think eribulin has become a very easy drug for the patient and for the oncologist as well. And it's also very effective. And there's nothing to really say that gemcite or platinum is superior to the eribulin, or eribulin is superior to the gemcite, cisplatin, but it's one of the easy drugs. So you can place the drug wherever you can, fit in. And if one is always the problem is bone marrow suppression, and with some of the drugs like gemcitabine, bone marrow suppression is a major problem, and therefore the LMN can replace that status. So I think I'm very happy that we could discuss so much in detail about the eribulin, and all of us are enriched in our knowledge about where to place the eribulin. Thank you very much. And thanks to all the people, all the experts who have come here and discussed the various points about the eribulin. Thank you, and thank you, Geneva.
Thank you so much, sir, for this wonderful, final comments from your end. And with this, we are at time. So thank you so much, everyone, for joining in today, our esteemed panel as well, for such an insightful discussion. And see you in the next one. Thank you. Good night. And Kishore, we can end today's meeting. And Kishore.